Grace and beauty are synonymous with women, whatever stage of their life they're in. We all work and prime ourselves so we can live life with ease. Primavix, priming women for life. Prime up for life's next chapter. Ease menopausal symptoms. When a woman reaches her 40s, she may begin to enter a new chapter of her life and start to experience menopausal symptoms. But this does not mean that grace and beauty will begin to fade away. With age comes the wisdom to know what their bodies need to stay in their prime. Help your premenopausal and menopausal patients ease their menopausal symptoms so that they can be at their prime every day. As hormones wane, women in the menopausal age can experience symptoms like hot flushes. They may notice their skin lose its elasticity and moisture. Aside from being uncomfortable, these can impact her self-confidence and even productivity. Primavix can help alleviate these symptoms of menopause. It has high level of gamma-linolenic acid or GLA and omega-6 fatty acids that help counter the effects of hormonal changes such as hot flushes. It can also help improve skin elasticity and moisture. With Primavix, you can help women get in the prime position to live the next years in ease. Prime your patience for life. Ease menopausal symptoms of maturing women. Primavix.
Primavix.
Today, a change in mindset is in order. With the arrival of the modern woman's newest ally in dealing with menopausal discomforts. Tibolone Amina. Amina has positive effects on women's health. Amina is a proven effective therapy against vasomotor symptoms such as hot flushes and night sweats. Amina improves mood and sexual well-being and prevents vaginal dryness. Amina reduces the risk of vertebral and non-vertebral fractures. Amina lowers cholesterol and triglyceride levels. Amina minimizes menopause-related decline in muscle strength. Amina protects against coronary artery disease. Amina reduces the risk of breast cancer. Tibolone Amina. Comfort from menopausal discomforts. Only from Biofem, the Women's Healthcare Division of Unilab. Amina.
Midnight at the oasis, send your camel to bed. Shadows painting our faces, traces of romance in our head. Heaven's holding a half moon, shining just for us. Let's slip off to a sand dune real soon and kick up a little dust. Come on, cactus is our friend. He'll point out the way.
Good afternoon, everybody.
Good afternoon.
Am I on?
Yes, Ma'am Duchess. Good afternoon. I will present you first, Ma'am Dutch.
Okay. I was told to present myself. Go ahead, May.
Okay. So, good afternoon. Welcome to MENOTalk Wednesday, a monthly first Wednesday webinar brought to you by the Society for Climacteric Medicine. So, today's webinar promises to be a very informative one, not just because of the topic, it's very interesting, but because our speakers and moderator are experts in this field. So, without further ado, let me introduce our moderator for today. So she's an Associate Professor 7 at the Division of Reproductive Endocrinology and Infertility, Department of Obstetrics and Gynecology, UP College of Medicine, Philippine General Hospital. She is currently the Vice President of the Philippine Society of Climacteric Medicine. She's a member, Editorial Advisory Board, Journal of the Asia Pacific Association of Gynecologic Endoscopy and Gynecology and Minimally Invasive Therapy. She's a member of the Council for Residence Education, Enhancement, and Development of the Philippine Obstetrical and Gynecological Society, Incorporated. She's also our past president in the Philippine Society for Reproductive Medicine. She holds an international master's degree in biotechnology of human-assisted reproduction and embryology from the RMA Global Education, University of Valencia, Spain. So without further ado, help me welcome our moderator for today, Dr. Maria Jesusa, Duchess Banal Sila. Ma'am Dutch.
Thank you very much, Nay, for that kind introduction. It's a privilege to be among our colleagues and to be moderating this afternoon's session on managing difficult menopause cases in the peri and menopause. So to give the opening prayer, let's welcome Dr. Vivian Bombita, our PSCM Region 5 Director.
Good afternoon. Let us put ourselves in the spirit of prayer. We praise and thank you, Lord, for this wonderful afternoon. Thank you for giving us the chance to come together and listen to our esteemed experts as they tackle some of the difficult conditions that we, in one way or another, may have encountered or will encounter in our gynecologic practice. Guide our discussion and open our minds and ears so we may fully hear and understand. May this webinar be a venue for abundant learning as we strive to give holistic care to our patients. This we ask in your holy name. Amen.
Thank you, Vivian. Okay, so for smooth discussion, may we review the house rules of our Wednesday webinar. So to ensure a clear webcast, only the speaker, chair, and moderator are allowed to use their microphones. First time Zoom users, I think this is not applicable because we have a Zoom webinar platform. Okay, so after each case discussion, you may write your comments or questions in the Q&A box, and then you will raise them during the open forum. So the chat icon is likewise located at the bottom of the screen. So this webinar is being recorded for access and review of attendees at a later date. And kindly fill out the evaluation and post-test forms at the end of the open forum, and the link will be posted at the chat box later on. Okay. So to give us the welcome remarks, may we call on the very hardworking president of PSCM, Dr. Prudence Aquino.
Hi, Duchess. Magandang hapon po sa lahat. Welcome to the July MENOTalk edition of the Philippine Society of Climacteric Medicine. I am Prudence V. Aquino, the president of the society. The concept that endometriosis is a disease that only affects women of reproductive age has prevailed since 1942. However, more often than not, we have seen patients in the perimenopause and beyond consulting with findings of endometriosis, symptomatic or asymptomatic. Excess estrogen in general represents a promoting factor for the disease, hence a cause of concern among health providers like us. If this disease is suddenly found persisting or newly found among the women in this age group. The management of endometriosis in women in midlife and beyond can be made even more complex depending on the associated needs and desires at the moment of consult. This afternoon, we are in for a treat. We have three distinguished speakers discussing three interesting clinical scenarios of endometriosis. Two are past presidents of the Philippine Society of Climacteric Medicine. All three are past presidents of the Philippine Society of Reproductive Medicine. Welcome, esteemed speakers, to this afternoon session. To navigate through this exciting panel discussions is our very own dynamic PSC Vice President, Dr. Maria Jesusa Banalcillo, serving as our moderator. Maraming salamat. A bonus this afternoon is a lecture from one of our board members, Dr. Gladys G. Tanangonan, to discuss EPO in the menopause. Thank you, Gladys. And to Dr. Vivian Bombita, our Region 5 Director, salamat po sa prayer. To our pharma partner, Unilab Biofarm, through Ms. Concepcion Connie B. Samson, the CMG Manager, maraming salamat muli. To the PSCMCME Head, Dr. Marinela Abat, her team, especially Dr. Mona Evelyn Sinelos, thank you for organizing this afternoon's webinar. Last but not the least, to Ms. Rose Mancinas, our Office Secretary, for her uncompromising assistance to all our webinars. Now let us sit back, relax, enjoy, and learn. Now back to you, our moderator, Dr. Duchess.
Thank you, Bossing. To give us an introduction to this very exciting afternoon's discussion, may we call on the equally prolific chair of the CME of PSCM, Dr. Marinela or Nay Abat. Nay?
Thank you, Ma'am Dutch. So the management of endometriosis is a very controversial and challenging issue as each is tailored to the needs, wants, and age group of the patient. So today we will learn from the experts on how to manage peri and postmenopausal endometriosis. This webinar and panel discussion aims to enlighten our participants on the hows and whys on the management of our patients. At the end of the webinar, our participants would be able to discern the best management option suited for the cases that they see in their clinics. So please take this opportunity to ask our speakers regarding cases that you see in your clinics and questions that you have always wanted to ask regarding endometriosis in the peri and postmenopausal patients. Back to you, Ma'am Dutch.
Thank you, Nay. So like what Nay and Prudence mentioned, we have three distinguished speakers. Each speaker will discuss one specific case. And then after all the cases have been discussed, we will open the floor for open forum. So we will save the open forum after all cases were discussed by our speakers. So to introduce them one by one, may we have the first speaker. So our first is the only thorn among the roses, but the most learned and the most distinguished. So we have Professor Delphine Tan. We know that he's the former chief of section of the reproductive medicine of St. Luke's, Quezon City. He's also a consultant at the Philippine Center for Assisted Reproduction. He's a past president of POGS, PSRM, PSG, and PSCM. He's a past member of the executive board of the Internal Menopause Society. He's an Honoria Acosta Season Memorial Awardee for research and the equally distinguished Baldomero Rojas Awardee. So he will be the discussant for the first case. Our next speaker is Professor Maria Antonia Habana. She's a professor 12 at the Department of OBGYN and Department of Epidemiology at the College of Medicine, University of the Philippines, Manila. She has the title of being a University Scientist 1 of the UP system. And she's the current president of the PSGE. She's a past president of PSRM in 2016. She's a current editor of the Philippine Journal of Reproductive Endocrinology and Infertility and an associate editor of the Fertility and Reproduction and the Philippine Journal of Obstetrics and Gynecology. So Ma'am Tonette will discuss the second case with us. And last but not the least, we have Professor Aideen Manalo. She's a Professor 7 of the UP College of Medicine of PGH. She's the former chief of the Division of Endocrinology and Infertility of the UPPGH. She's currently the Assistant Secretary General of the IFFS, or the International Federation of Fertility Societies, and she will serve this position until 2025. She's currently also the Vice President and founding member of the Philippine Society for Fertility Preservation. She was past chair of the she's the current chair, I'm sorry, of our PSCM annual convention. She has been the chair for the past 2 years. She's a past president of PSCM, PSRM. She's also an associate editor of Fertility and Reproduction, which is the Aspire Journal. She's an editorial board of the BMC Women's Health. She has been a past board member of PBOG in 2006, 2007, and 2018 to 2020. She was awarded the Howard and Conchita Redmond Professorial Award for 2021 up to 2023, and she also earned her international master's degree in human embryology and assisted reproduction in Spain. Okay, so Dr. Manalo will be our discussant for the third case. Okay, so now let's proceed with the cases. So the first case is all about an asymptomatic ovarian endometriotic cyst, and the discussant is Professor Delphine Tan. So I will narrate first the case to you. Next, please. So for the first case, we have SS, a 50-year-old, Gravida 1 Para 11001. She's an insurance agent and was referred due to hot flushes and non-inflammatory joint pains. She was diagnosed with systemic lupus erythematosus at the age of 42 and is currently controlled on prednisone 5 milligrams once a day and hydrochloroquine 200 milligrams once a day. She had her menopause at the age of 49. She's now 50. A pap smear was done and a transvaginal ultrasound was also done, which incidentally showed a right endometriotic cyst measuring 3 by 2.7 by 2.3 cm with ground glass echoes. Her body mass index is 20 with a normal renal liver function test and normal CA125. So the main question, but Professor Tan will discuss other salient points, is that how will we manage the asymptomatic endometrioma in this patient and address her menopausal complaints as well. Okay. So I give now the floor to our discussant, Professor Delphine Tan.
Sorry. Okay, taking this chair. That just is okay.
We can see your slide, sir. Yes, po.
Okay, thank
Go
you very
ahead.
much. Thank you, Duchess.
Thank you.
Right. Good afternoon, everybody. This is my disclosure. I don't think there is any conflict of interest. Let me just recapitulate the case so it will remind me of what are the essential points. We have here that the case is entitled Asymptomatic Endometrioma, which I kind of disagree with, but let me explain later. She's 50 years old. She was referred for menopausal symptoms. She had her last menstruation at 49. So she is post-menopause, early menopause, if you wish. At 42 years of age, she was diagnosed with systemic lupus erythematosus, which apparently is controlled by corticosteroid and antimalarial medications. Pap smear was taken, but we don't know the result, but I assume it's negative. And she had a transvaginal ultrasound and incidentally found an endometrioma that is about 2.5 to 3 centimeters with ground glass echoes, meaning that this most likely is benign. BMI is 20. She had normal renal and liver function tests, which I think is too much test just to start HRT. And maybe because of endometrioma, she had CA125 taken, and it's normal. So the questions that were asked was, how will you, that's me, manage the asymptomatic endometrioma, and how will you address her menopausal symptoms? But I think there are actually three questions that we need to answer before we discuss the case. And what I'm going to do is answer these three questions so I can assemble all the facts and the information necessary for me to prepare a management plan for this patient. So the question one is, how will you address her menopausal symptoms? Question two is, how will you manage the incidental postmenopausal asymptomatic endometrioma? The words incidental and postmenopausal are in brackets, and I will explain to you a little why in a little while. And then how will you deal with the history of systemic lupus, erythematosus, and managing the case? How will you manage the menopausal symptoms in a woman with endometrioma and a history of SLE? Very simple, no? Anyway, so how will you address menopausal symptoms? My answer is very politely, but I will strongly recommend MHT. And I make this recommendation not only because she has menopausal, not because she has menopausal symptoms, but regardless of whether she has endometriosis or not, and regardless of whether she has SLE or not. The reason is because if you look at the symptoms of the menopause, we usually categorize them into early, intermediate, and late, as if they are discontinuous sets of symptoms that comes one after the other. But in reality, this is a continuous process. What it means is that what happens early in the menopause, specifically in the perimenopause, can have effects long into the menopausal life of a woman. For example, if you look at hot flashes, we now consider hot flashes as more than temporary menopausal symptoms. They're actually biomarkers of chronic diseases. So from symptoms to chronic diseases, from symptoms of the perimenopause to chronic diseases, sometime 5 to 10 years after the onset of the menopause. And we have, for the last 10, 12 years, accumulated enough evidence to say with confidence that persistent vasomotor symptoms are associated with increased risks of metabolic syndrome, diabetes, cardiovascular disease, osteoporosis and fracture, depression, sleep apnea, cognitive impairment, and even signs of Alzheimer's disease. White matter hyperintensities are evidence of beginning Alzheimer's disease on MRI. To the point that a group of renowned, I would say, serious students of menopause, and you know the names of these people, from Professor Langer to Walt Luthian, they had the audacity to tell the United States Preventive Services Task Force that the task force is wrong in relation to menopausal hormone therapy for primary prevention. Now, what has it got to do with what we're discussing? Because here, since 2002, when WHI came out, we've been hearing this statement that menopausal hormone therapy should not be used for the prevention of chronic diseases over and over again. And that is what USP CSTF task force is saying. And then these people are saying, you are wrong. And they cited this fact that untreated vasomotor instability, which is associated with increased risk of hypertension, osteoporosis, cardiovascular disease, depression, and cognitive impairment. And controlling these hot flashes is actually preventing disease. So what does it mean? It means that you have vasomotor symptoms, I treat it correctly, and not only will I relieve the vasomotor symptoms, but I'll also prevent you from having chronic diseases that may happen downstream 5, 10 years after the onset of the menopause. So this is actually evidence that MHT can be used for the treatment of for the prevention and possibly even treatment of chronic diseases. So on this regard, I would suggest that whether you have endometriosis or you have SLE or not in the postmenopause, the moment you have menopausal symptoms, please consider very strongly the use of menopausal hormone therapy, not only for the relief of symptoms, but also for the prevention of chronic diseases. But of course, it has to be given at the right time, which is during the perimenopause, where it all starts. So question 2, how will you manage the incidental postmenopausal asymptomatic endometrioma? My short answer is I will recommend surgery. And based on this discussion, Let's first of all discuss the title of my presentation, which is Asymptomatic Endometriosis or Endometrioma. Right? And there is only one guideline that I found that has a definition for asymptomatic endometriosis. And this is the 2014 ESRE guideline, which says that asymptomatic endometriosis is the incidental finding of peritoneal, ovarian, or deep endometriosis without pelvic pain and or infertility. And you find incidental asymptomatic endometriosis at laparoscopy for indications other than endometriosis. For example, for women undergoing tubal sterilization, one of the earliest studies, 1991, 45%. But I assume that this is because they also did the laparoscopy for acute pain. And many of this acute pain may be due to unrecognized endometriosis. Because if you look at the second study, where they did it only for tubal sterilization, the incidence of incidental endometrioma is just 3.7. Polycystic ovary syndrome, much more common. One study, 16.9 incidence of endometriosis, clinically not complained of, but recognized at laparoscopic ovarian drilling. And in a meta-analysis of 4 PCOS studies, the pooled result is about 7.7%. Now, the rates doesn't really matter very much. But what I'd like to point out is that in all these 4 studies, or 3 studies and then 1 meta-analysis, all these patients are premenopausal patients. They are not postmenopausal, as in our case, because if you, and this is the reason why the ESRE 2022, the recent one, says that when you find incidental endometriosis, you should counsel the patient about it, but you should not routinely perform surgical excision or ablation at the time of surgery or later, and you should not prescribe any medical treatment because there are no reasons to do that. And they base this supposedly strong recommendation on a paper by Moen that was published way back in 2002, which says that there is little risk that asymptomatic minimal endometriosis found incidentally will become symptomatic. So what I'm saying is when you use the word asymptomatic, maybe we should use it for women who are premenopausal, not postmenopausal, because it can give us the wrong impression that there is nothing wrong. Now let's talk about postmenopausal endometriosis. And here, ESRE made a complete turnaround. Acknowledging that endometriosis menopause can be active and symptomatic, it suggests that we consider, and this is GPP, the risk of malignancy whenever we have a pelvic mass, and that should be worked up according to what the national guideline says. And surgical treatment is recommended to enable histological confirmation of a diagnosis. So from being conservative in the premenopause to being extirpative in the postmenopause, what about the perimenopause? So what happens at the middle of this continuum? So let's continue. Now, we did a study some time ago with, we did this with JCL Maria, and we reviewed all the cases of postmenopausal endometriosis that were reported in literature at that time. And we accumulated about 198 cases from 89 published articles. And we found that out of these 998 cases reported in literature of postmenopausal endometriosis, 62 were associated with malignant degeneration, giving us a percentage of 31%. This, of course, is not the incidence of malignancy compared to the general population. This is just within the reported cases of 198. And the most common is endometrioid carcinoma and clear cell carcinoma. Now, I was asking earlier, what about the perimenopause? Somewhere between premenopause and postmenopause, what do we do? This is a study which I would like to walk you through. Menopausal women with perimenopausal and postmenopausal women with confirmed endometriosis. And they looked at the coexistence of endometriosis with various benign and malignant conditions. Just like you, because for the purposes of our presentation, just look at this. This is endometriosis-associated ovarian cancer. The blue bars are perimenopausal, the red bars are postmenopausal. The blue bar is 4.3. That's the percent incidence. And the red, and for the postmenopause, it's 6.5. And the NS there means not significantly different, is because they feel that these two figures are the same, that whether it's pre and for perimenopausal or postmenopausal, there's no difference in the conversion of endometriosis to malignancy. Now, this to me confirms that age and menopause are risk factors for malignant transformation of endometriosis. Now, if you remember the usually quoted incidence of endometriosis-associated ovarian cancer is 1.9%. So this is definitely very high. And so clinicians should be aware that there is a correlation between endometriosis and endometriosis-associated ovarian cancer in both peri and postmenopausal women. Right? Now, what about the isolated endometrioma? Because it appears that there is just endometrioma in this case and nothing else. Of course, I'd like to remind you that isolated ovarian endometrioma is more of a myth rather than a reality. In one of the latest studies on this subject, in 255 symptomatic women with endometrioma with a diameter of at least 2 centimeters, the single isolated mobile endometrioma was seen in only 15%. And the rest are actually associated with bilateral endometrioma in 25, rectal endometriosis, uterosacral ligament thickening, adhesions, and adenomyosis. To me, more important is this paper by David Redwine. This is a paper published 23 years ago, but even at that time, Redwine is already aware, because Redwine is a man who does only surgery for endometriosis, devoted his life to doing nothing but surgery for endometriosis. At that time, he realized 23 years ago that ovarian endometriosis is actually a marker for more extensive pelvic and intestinal disease. So when we say extensive pelvic and intestinal disease, please read deep endometriosis. And here he shows, because he computed this, put it in his computer, all the sites of involvement of endometriosis. And the pelvic sites are the ones that predominate. If you look down the graph here, cul-de-sac, 72% of patients have lesions in the cul-de-sac. Still 52% of all patients undergoing surgery for endometriosis has left broad ligament involvement, and so on and so forth. And ovaries, maybe about just 18%. They had 1,785 cases whom he personally operated on, and only slightly over 1% were cases that were exclusively ovarian, and 99% of the cases actually had a combination of sites of endometriosis. So if you look at the right side, you see here the mean number plus or minus standard deviation of areas involved by endometriosis. And the blue is pelvic areas and the red are intestinal areas. And whenever there is an OMA, there is a higher risk of having pelvic, not risk, but higher frequency of pelvic areas involvement of pelvic endometriosis and a higher frequency of intestinal endometriosis. And within our own analysis of postmenopausal endometriosis, we also found that out of 198 cases, 103 of these patients were having extragonadal spread. And there is a tendency for postmenopausal endometriosis to be constrictive and or obstructive. 52% of our reported cases have extragonadal endometriosis, and the most common sites of possibly constrictive or obstructive cases are in the ureter and in the intestine. So question 3, how would you deal with the systemic lupus erythematosus? We are not experts on SLE, but it is necessary that we check its status and activity before we start here on MHT. Let me explain. First of all, we look into the incidence of anti-phospholipid antibodies in women with SLE. This is a paper published a few years ago, which it says that 30 to 40% of SLE patients test positive for APL, which positive test can have an impact on SLE presentation, management, and prognosis. And actually, we're looking at venous thromboembolism. Because if you look at this is the meta-analysis and looking at the increased risk of clinical manifestations in APL positive SLE versus APL negative SLE. So we're looking at odds ratio. I just want you to look at venous thromboembolism. LA, that's lupus antibodies, and the ACL, that's anti-cardiolipin antibodies, and A beta 2 GPI. These are the types of APL. But we don't have any data with anti-beta 2 GPA. The data are available for LA and ACL. And you can see that there's significantly increased risk of venous thromboembolism among women who have high levels of LA. High risk of venous thromboembolism among women with positive for LA and positive for ACL. These are the two types of APL and antiphospholipid antibodies. Now, what about SLE and cardiovascular disease? A review of 28 studies on the association between SLE and atherosclerotic cardiovascular disease disclosed that for SLE patients compared to controls, there is the incidence rates are significantly higher for myocardial infarction. The red bar is SLE, the blue bar are general population control, significantly higher for MI, for ischemic stroke, for cardiovascular disease. And this is reflected in the hazard ratio of 2.61, 2.14, and 2.28 for myocardial infarction, ischemic stroke, and cardiovascular disease, and all of them are statistically significant. What about SLE and osteoporosis? This is a review and meta-analysis, 31 articles 3 years ago, looking at the incidence of osteoporosis in patients with SLE. This is a meta-analysis of risk factors that may place SLE patients at higher risk for osteoporosis. This is not hazard ratio, this is a mean difference and 95% CI. Overall, this is 2.03, that's 103% increase in the incidence of osteoporosis in patients with SLE. Age is a very important factor, disease duration, subgroup, cumulative corticoid steroid dose. Higher the dose, the higher the risk. And then duration of therapy, and of course, the onset of the menopause. So there is therefore this correlation between SLE and osteoporosis. And why am I mentioning this? Because we're going to deal with this menopausal woman and whether she's prone to cardiovascular disease or prone to osteoporosis is a significant part of the information we need whether to give HRT or not. Now, what about SLE and menopause and HRT? It's actually more of HRT than menopause. In a paper recently published by Ann Campbell, I'll walk you through the slides, and the role of the menopause is not really much. There's actually evidence that with the menopause, SLE's activity may become less and less, but this is not really due to the onset of menopause, it's due to aging. But there is a relationship between lupus erythematosus activity and menopausal hormone therapy. If you look at the first study, necessary study, as the duration of use increases, let's say from 1 to 5 to 11 years, the risk of incident SLE increases too. In another nurses' health studies where there is emphasis on surgical menopause increased the risk of incident incident lupus erythematosus with surgical menopause. The Mayer study is much more interesting. Long-term users increased, short-term users no. But what I'd like you to remember is this. If you look at estrogen users, estrogen users is statistically significant increase, actually highest, 5.3. But if you look at those who were using E plus P, it was actually decreased. So estrogen is not good. E plus P is good. Now, let's go back to surgical menopause. Why is surgical menopause increased? The risk is increased for systemic lupus erythematosus. It's because even if they are not producing endogenous estrogen anymore. They were given estrogen, exogenous estrogen, and that's why surgical menopause managed by estrogen replacement therapy may increase the risk of incident systemic lupus erythematosus. Right? So that creates havoc in our mind when we try to sit down and manage this case. Now, there's also a risk for flares, but this is not very common. There are 5 studies here in this slide. Only one was positive for a difference in the risk of severe as well as mild to moderate flares. But nevertheless, it should be important in determining whether MHT should be given or not. So my last few slides, how will you manage the menopausal symptoms in a woman with endometriosis and a history of SLE? Now, first of all, how do we manage the postmenopausal endometrioma? I will work this up first for extraovarian and deep endometriosis, right? We probably need to have a more extensive pelvic evaluation, ultrasound. I don't think we need to have an MRI, but a good ultrasound will be necessary with a good sonologist. And then I will consider risk of malignancy, even if she's asymptomatic. She's perimenopause, and this is late onset endometriosis. I would expect endometriosis to be earlier in onset. This is at 40, or rather at 50, when she was found to have endometriosis. To me, this means that she must have had endometriosis a long time ago, but because she was not complaining of anything, they didn't find it not until at 50 years of age. And for this basis, I will recommend surgery. Could be a salpingo-oophorectomy, not a cystectomy, a salpingo-oophorectomy. We are past preserving ovarian reserve, and I think it's time to remove this tube as well as the ovary. Or I will discuss with the patient possibility of hysterectomy and salpingo-oophorectomy, but that's something that if she wants, but I will be content with a simple procedure like an SNO. But whatever surgery is done, whether it's a simple SNO or a more extensive hysterectomy and bilateral SNO, we need to excise all visible endometriosis. So managing endometrioma laparoscopically is not really an easy task if you deal with extraovarian disease, which is actually quite common and really very common in women with endometrioma. Now, how do I deal with the history of SLE? I would probably refer this patient to her previous doctor because I want to find out the status of her SLE. I'm concerned about the risk of exacerbation and flares, especially when I give her MHT, and determine the level of antiphosphorylated antibody because I would not want to give MHT to a patient with high levels because of the possibility of venous thromboembolism. We need to evaluate cardiovascular risk. There are 3 reasons for this. Endometriosis increases risk of cardiovascular disease. SLE increases risk of cardiovascular disease. Menopause increases the risk of cardiovascular disease. And we need to know her cardiovascular status. And then we need to evaluate too the risk of osteoporosis because SLE is associated with increased bone loss and fractures. So how do I manage the postmenopausal symptoms? Only after surgery. And assuming SLE is inactive or stable, right? APL is negative, and there's no history of thrombosis. And together with lifestyle measures, I will recommend MHT. The choice will be transdermal estradiol plus micronized progesterone or dydrogesterone, even if she has hysterectomy. It's because we need to control possible recurrence of endometriosis, and estrogen plus progesterone actually decreases possibility of incident systemic lupus erythematosus and flares. Vaginal estradiol should be available especially for those with genitourinary syndrome. And the final question is, can Tibolon be used in a woman with a history of endometriosis or a history of SLE in the presence of endometriosis or treated endometriosis at 50 years of age? Let me tell you the answer, which is a tentative answer because this is the only study that I found in the literature that used Tibolon in postmenopausal women with systemic lupus erythematosus. And it's a pilot study, just about 30 women. So the results are quite tentative, but good. So these are 30 women with inactive or controlled SLE. They were given a 12-month course of either Tibolon, 2.5 milligrams per day, or placebo. The most important point there here, however, the most important point here in this study is the incidence of flares or exacerbations. And this was measured by the SLEDAI score. SLEDAI stands for Systemic Lupus Erythematosus Disease Activity Index. And you have severe flares and you have mild to moderate flares. Now, this is 0 to 10, that's the SLEDAI score. And then the higher the score, the more severe the flare. And you can see that the flares that were recorded in these patients were quite low in frequency and mild to moderate. And compared to placebo, the Tibolon is in red, placebo is in black. No difference actually between placebo and Tibolon. So what it means is that it may increase the risk of flares, but that's no more than with placebo. And there is no incidence of severe flare in these women who received Tibolon for 1 year. Now, as far as the biochemical profile is concerned, there were 2 tests that were different from each other between placebo users and Tibolon. There was a decrease in triglycerides, 6 months and at 12 months for those on Tibolon, but there was also a decrease in HDL cholesterol for those on Tibolon at 6 months and 12 months. Otherwise, the biochemical profile is completely the same. What about the menstrual symptoms? And what this was, the Cooperman index shows that there is significant control or good control of menopausal symptoms at 12 months. You see the Cooperman score significantly less, 9.5 against 16.8 for patients on the placebo. So in conclusion, after 1 year of Tibolon in women with inactive, stable SLE, the flares are very minimal. They are mild to moderate, low frequency, actually just the same as placebo. There were no severe flares. Cooperman index shows significant control of menopausal symptoms. The laboratory tests are the same between placebo and Tibolon, except for a reduction in triglycerides, and a reduction in HDL cholesterol. There were no adverse events, no breast cancer, other cancers, venous thrombosis, arterial thrombosis, and death. So can Tibolon be used for patients with systemic lupus erythematosus to treat her menopausal symptoms and the possible presence of endometriosis? The answer is a tentative yes, because the study is just a pilot study, but I think it can be used. So on this note, I would like to thank you for listening. Thank you very much.
Thank you very much, Professor Tan. That was a very extensive discussion. The lit review of Professor Tan was very thorough, and I'm sure our audience has many questions. So please write the questions in the Q&A box and we will address them later at the open forum. Now to discuss with us the second case. The second case is on a perimenopausal woman suffering from endometriosis, adenomyosis, but still desirous of pregnancy. So here's the case. We have RA, a 42-year-old, newly gravid with a body mass index of 24 kilograms per meter squared, complaining of increasing dysmenorrhea and pelvic pain for 2 years. She also noted increasing menses, now consuming 5 to 6 regular pads per day and seeking consult. She has been trying to get pregnant for the past 2 years and was given 2 cycles of letrozole and 2 cycles of clomiphene citrate with timed intercourse. The anti-Mullerian hormone is 0.52 nanograms per ml, and the hysterosalpingogram showed normal results. Semen analysis was likewise normal. So now she is seeking second opinion, mostly for her fertility concerns. So to discuss with us this case, may we call on Professor Maria Antonia or Ma'am Tonette Habana.
Okay, thank you, Duchess. I'd like to share my slide. Okay, so I hope you're able to see that. Yeah. So I'll go.
Yes, ma'am.
Great, thank you. Thank you so much for that. So thank you again, Duchess, for your generous introduction. And I'd like to take this opportunity also to congratulate Dr. Tan again for an excellent lecture. So just to recap, the case is RA, so 42-year-old, BMI 24 with increasing dysmenorrhea and pelvic pain, and apparently also heavy menstrual bleeding. And she's been trying to get pregnant for the past 2 years. No? So the AMH is as follows: HSG and semen analysis were normal. So she consulted you or me for second opinion. No? So what is the diagnosis? So it's primary infertility for 2 years, secondary to a female factor. We have advanced age, she's 42, diminished ovarian reserve, her AMH is low, she has uterine and pelvic factors such as pelvic endometriosis, adenomyosis, and she is overweight. So the initial workup that I received was there was a measurement of ovarian reserve, that was the AMH, the semen analysis, which was normal, and the assessment of the fallopian tubes, which turned out to be normal. Okay, so we'll break it down into problems because the patient actually has quite a number. So we'll start off with advanced age and diminished ovarian reserve. And we know that fertility in women peaks between the ages of 20 and 24, and it declines with increasing age. So our patient is 42 years old, so as much as 95% lower. And it is said that age is the single most important factor affecting the probability of success in ART. Now, both age-related decline in female fertility and an increased risk of miscarriage can be attributed to an increase in the proportion of abnormal oocytes in an aging and shrinking follicular pool. No? So as you can see in the graph, as the number of follicles decreases, oocyte quality also declines. No? So there's an increase in meiotic dysfunction, disjunction rather, an increasing rate of oocyte and embryo aneuploidy. Now, why do we have to measure ovarian reserve? No? So it is aimed at identifying individuals at risk for diminished ovarian reserve. And this will help identify women more likely to exhibit a poor response to gonadotropin stimulation and potentially have a lower likelihood of achieving pregnancy with treatment. And it is most useful in women at high risk of decreased ovarian reserve, such as women who are in the perimenopause or like RA, who's 42 years old. So it adds more prognostic information to the counseling and planning process to help couples choose among different treatment options. So best overall strategy is to limit ovarian testing to women at increased risk for having a diminished ovarian reserve. And on the table, you'll see when is testing justified. No? So for our particular case, our age is 42 years old. So yes, it is justified to do ovarian reserve testing. And the other reasons would be unexplained infertility, family history of early menopause, previous ovarian surgery, chemotherapy or radiation, smoking, demonstrated poor response to exogenous gonadotropin stimulation, and planning treatment with ART. So this is actually a table that I got from the practice committee of ASRM. This was dated 2015, and it's a summary of the screening test of ovarian reserve. 10, 15 years ago, we used to do day 3 FSH, but now this has been widely replaced already by your serum AMH. The next thing that we can use is your antral follicle count. Inhibin B is not done routinely, and you have your clomiphene citrate challenge test, which is no longer recommended. Okay, so just some words on AMH. No, so if you have an AMH of 0.2 to 0.7, it suggests poor response to stimulation. Our patient, our AMH is 0.52. It has proven neither sensitive nor specific for predicting pregnancy. But low AMH levels has a high specificity as a screening test for poor ovarian response. But there's insufficient evidence to suggest it's used to screen for failure to conceive. So magkaiba. No, it will tell you if the response will be good or poor, but it will not predict pregnancy. How about our antral follicle count? No, it's an indirect but useful measure of ovarian reserve. So low antral follicle counts of 3 to 4 follicles, again, poor response to ovarian stimulation and failure to conceive. No? So the high specificity of a low AFC makes the test useful for predicting poor ovarian response and treatment failure, but its clinical utility is limited by its low sensitivity. So in the practice committee of ASRM, and this was released just in 2020, it talked about the value of ovarian reserve. So do markers of ovarian reserve in infertile women predict treatment success after ovarian stimulation and IUI? And the best evidence to date suggests that markers of ovarian reserve do not predict the likelihood of success following ovarian stimulation and IUI. And extremely low AMH values may be used to appropriately counsel women regarding suboptimal response and yield, but it should not be used to refuse treatment. So I think that's very important to remember. So even if RA had a low AMH, it should not be used to refuse treatment. No? And AMH and AFC have only a weak association with qualitative outcomes such as oocyte quality, clinical pregnancy rates, and live birth rates. And despite a lack of evidence that more ovarian testing improves outcomes, like you can do several, no, it is common for patients to have multiple screening tests performed. So it's not unusual to receive a patient that has a day 3 FSH, an AMH, and an AFC. No? And in addition to adding to overall expense, discordant results may complicate management and confuse the patient. No? So although generally positively correlated, AMH and AFC may be discordant up to 30% of the time. Okay. So right now, it's recommended to use, let's say, just AMH and or AFC. The second problem of RA is pelvic endometriosis. And why do we say so? No, so 25 to 50% of infertile women will have endometriosis, and 30 to 50% of women with endometriosis have infertility. And fecundity rate in women with untreated endometriosis is estimated to range from 2 to 10%. No, so how do we diagnose? No, just a short review of endometriosis. So clinical diagnosis, we have our diagnostic test, imaging, and our surgical diagnosis. And I want to bring you back to ESHRE. They came out with a 2022 guidelines on endometriosis. And just to orient you, the clinical recommendation is not just based on evidence. So the level of evidence is indicated, but then they also took into consideration the acceptability, the cost, the benefits versus harms, and the patient values. Okay, so if you look at the middle part on the right, that's clinicians. If you have a strong recommendation, that means most patients should receive the recommendation course of action. And if we have a weak recommendation, then different choices will be appropriate for different patients, and clinicians must make greater effort in helping patients to arrive at a decision consistent with their values and preferences. This is shared decision making, and I might add for our country, the cost. Okay, so when it comes to clinical diagnosis, again, consider the diagnosis of endometriosis in individuals presenting with any of the following. Our particular patient, RA, had increasing dysmenorrhea and pelvic pain. No? So it's consistent with the diagnosis of endometriosis. We must do a physical examination. I'm a believer of doing physical examinations. And it would include the vaginal examination to identify deep nodules or endometriomas. Okay. In women with suspected endometriosis, further diagnostic steps, including imaging, should be considered even if the clinical examination is normal. So let's say RA has a normal physical examination, but you're strongly considering endometriosis, then further testing is needed. Okay. So what can you do? No? So clinicians are recommended to use imaging. So you have ultrasound or MRI in the diagnostic workup for endometriosis, but they need to be aware also, again, a negative finding does not exclude endometriosis, particularly for dealing with superficial peritoneal disease. So again, that's very important. And it's important also to explain that to the patient. No? How about surgical diagnosis? In patients with negative imaging results or where empirical treatment was unsuccessful or inappropriate, let's say you already gave medical management and the pain, let's say, persists. No? So the guideline development group recommends that clinicians should consider offering laparoscopy for the diagnosis and treatment of suspected endometriosis. And the group also recommends that laparoscopic identification of lesions is confirmed by histology. Although negative, again, histology does not rule out the diagnosis. Okay, so Duchess mentioned earlier that this patient actually had increasing dysmenorrhea and pelvic pain. So since we're considering endometriosis, this RA may be offered NSAIDs or other analgesics, either alone or well in combination with other treatments, which would mean hormonal, to reduce endometriosis associated pain. Why did I put an X on the hormone treatments? Well, because she's coming in for infertility. And so we move over to endometriosis associated infertility, and we're aware that there are many causes. And this is a very nice figure that shows it can go from peritoneal inflammation if we're dealing with just minimal or mild endometriosis, but even for 3 and 4 stages, you can have already anatomical distortion. And what is the treatment? No? So expectant management is an option for women who are hesitant to pursue ovarian stimulation with or without IUI or IVF. However, the fecundity rate is lower in women with endometriosis. Um, but women with endometriosis can conceive without intervention if they do not have advanced stage disease and if they're less than 35 years of age. So we have to remember our age is already 42. So the question is, infertile, do hormonal therapies, are they effective for infertility associated with endometriosis? So for ovarian suppression in infertile women with endometriosis, clinicians should not prescribe ovarian suppression treatment to improve fertility. So for RA, if you do give hormonal treatment, it is more for pain, but not for her infertility. And since she wants to conceive, we try to withhold hormonal treatment because this will delay her getting her con- getting get sorry to conceive. No, it will delay her ability to conceive. So we do not give hormonal treatment as of yet. No. And then for women seeking pregnancy, they should not be prescribed post-operative hormone suppression. This is after surgical treatment with the sole purpose to enhance future pregnancy rates. And those women who cannot attempt or decide to conceive immediately after surgery, they may be offered hormonal therapy as it does not negatively impact their fertility and improve the immediate outcome of surgery for pain. So if your patient, if RA underwent surgical therapy, let's say for pain, there's no need to give post-operative hormone suppression because we want her to get pregnant immediately. However, if she's not sure she wants to get pregnant immediately, or she wants to delay conception, which I think she shouldn't because she's 42, then you may give hormonal treatment. So how about deep endometriosis? And Dr. Tan mentioned deep endometriosis earlier. No? So operative laparoscopy could be offered as a treatment option for endometriosis associated infertility in stage 1 and 2 as it improves the rate of ongoing pregnancy. But look, this is a weak recommendation. So it should be, again, individualized treatment. No? And then clinicians may consider operative lap for the treatment of endometrioma associated infertility as it may increase their chance of natural pregnancy, although no data from comparative studies again exists. Again, this is a weak recommendation, thus it should be individualized. There's no compelling evidence that exists that operative lap for deep endometriosis improves fertility. Operative laparoscopy may present a treatment option in symptomatic patients, meaning they are in pain, wishing to conceive. And the guideline development group recommends that decision to perform surgery should be guided by the presence or absence of pain symptoms, patient age and preferences, history of previous surgery, presence of other infertility factors, ovarian reserve, and estimated endometriosis fertility index. So all this has to be taken into consideration when the decision for surgery will be done. Now, is medically assisted reproductive techniques effective for infertility-associated endometriosis? So for stage 1 and 2, clinicians may perform IUI with ovarian stimulation instead of expectant management as it increases pregnancy rates. And then although the value of IUI in infertile women with stage 3 and 4 with tubal patency is uncertain, the use of IUI with ovarian stimulation should be considered or could be considered. Okay. How about ART in women with endometriosis? So ART can be performed for infertility associated with endometriosis, especially if tubal function is compromised. In our particular case, RA, her tubes are patent. No? And then a specific protocol for ART in women with endometriosis cannot be recommended as of this moment. Women with endometriosis can be reassured regarding the safety of ART since the recurrence rates are not increased compared to those women not undergoing ART. And clinicians may use antibiotic prophylaxis at the time of oocyte retrieval, although the risk of ovarian abscess formation following follicle aspiration is low. No? So this looks at ART now with endometriosis. Now, are medical therapies effective as an adjunct to treatment with ART for endometriosis-associated infertility? So the extended administration of your GnRH agonist prior to ART treatment to improve live birth rate with infertile women with endometriosis is not recommended as the benefit is uncertain. And there's insufficient evidence to recommend prolonged administration of the COC progestogens as a pre-treatment to ART to increase live birth rates. No? So again, this is different if your patient already wants to delay pregnancy, then you may give. But if she's going to ART already, then there's no reason to give it anymore. Now, this concerns, I think, most of us, no, when we receive a case like RA, and the question is, should surgery be performed prior to treatment with ART to improve reproductive outcomes? So before you refer your patient to your reproductive medicine specialist, should surgery be performed, no? So when we're dealing with peritoneal endometriosis, so clinicians are not recommended to routinely perform surgery prior to ART to improve live birth rates in women with stage 1 and 2, as the potential benefits are unclear. So if it's superficial or peritoneal, there's no need to do surgery. How about if the patient has OMA? No? So again, routinely to perform surgery prior to ART to improve live birth rates. Again, there's no benefit, and surgery is likely to have a negative impact on ovarian reserve. So we have to remember that. However, if surgery is improved, surgery may be done if you want to improve endometriosis-associated pain, or if you want to improve on the access to the follicles. So those are the only two reasons of doing surgery prior to ART, and we can go into a discussion later on the techniques for that. And for deep endometriosis, the decision to offer surgical excision of deep endometriosis prior to ART should be guided, again, mainly by pain symptoms and patient preference. No? Again, its effectiveness on reproductive outcome is still unknown. Okay, so this particular table now shows you if your patient is in stage 1 and 2 endometriosis or 3 and 4, what could be done. So I'd like to turn your attention to the lower portion. So for older women or women aged more than 35 years, so our patient is 42, we want to have a more aggressive therapeutic plan with either IUI with controlled ovarian stimulation or refer already our patient for ART. So our next problem is adenomyosis. So she's 42 years old with diminished ovarian reserve. She most likely has pelvic endometriosis. Then we now talk about adenomyosis. And this graph shows how adenomyosis and endometriosis may be similar, but they're completely different. And our patient now presents not only with pain, but also heavy menstrual bleeding. And infertility is found in 11 to 12% of patients with adenomyosis, and it may be due to uterine hypercontractility or impaired stromal decidualization due to progesterone resistance or a chronic inflammatory endometrial environment. And again, the prevalence of adenomyosis in the infertility population undergoing IVF-ICSI is around 6.9 to a high 34.3%. And the pregnancy rate after IVF happens in around 40.5% of women with adenomyosis compared to nearly 50% in those without. And they think that the junctional zone thickness could be a predictive factor of repeated implantation failure in women who underwent IVF, suggesting that adenomyosis may impair embryo implantation in IVF cycles. So this is something relatively new, and we're waiting for more studies now to define this. Again, our patient present with increasing dysmenorrhea and pelvic pain for 2 years and increasing menses, now consuming 5 to 6 regular pads per day, quite consistent with the picture of adenomyosis. And I'm just showing this slide. I think it's more for your reproductive medicine specialist. I just want to show that adenomyosis can be classified as slight or beginning endometriosis, and then you have your severe disease. And you can do various things. If a patient is referred for IVF, then hysteroscopic treatment or even GnRH may be done prior to transfers and so forth. Then we go to the last problem of our patient. So she is overweight. maybe bordering on the obesity already. And we know that women associated with obesity have menstrual dysfunction, decreased fertility, and an increased risk for miscarriage and obstetric and neonatal complications. And men too, no, associated with abnormal semen parameters. No? So this is our patient. She has multiple problems, and to top it all, she's in the perimenopause. So we're looking in the background of decreased ovarian reserve. And I place this here, patient commitment. It's very important. When you get a patient like this, you have to discuss with her that she has to really, what are her hopes, what are her dreams, and if she really can spend the time, and you have to prepare her for this journey. An infertility journey has its ups and downs. So, and you're pressed for time because she's 42. So patient commitment, and of course your commitment as her physician is very important. So again, these are the problems of our patient. We can do our initial workup, and she came already with an AMH. If she didn't come, one option for those who do not have an AMH is to day 3 FSH. Now, ultrasound is readily available. So when you ask for a transvaginal ultrasound, you can include your antral follicle count. You can request your favorite sonographer to use the International Deep Endometriosis Analysis category. So you know if you're dealing with a DIE case, or usually OMA, they're able to diagnose this readily. And then also look at adenomyosis. So right now they use the morphological uterus sonographic assessment. Let us not forget our patient is overweight and obese. So we have to screen for diabetes. So we can order our fasting blood sugar and HbA1c, perhaps ask for a fasting lipid panel, liver function test, and even a thyroid function test to find out why she is overweight or obese. If this is in our history taking, we can elicit her diet and her lifestyle. If she has a sedentary kind of lifestyle, then we can elicit that in our history taking, but we can ask for these particular labs to help us out. And again, based on our clinical findings, our physical examination, our ultrasound findings, even our laboratory tests, let's say our patient has pelvic endometriosis, we can divide them into either superficial or peritoneal if she has an OMA or a DIE. And on the other hand, you have your adenomyosis, again, if it's slight or beginning, moderate, and severe. So there's still much work really here on adenomyosis. Sometimes some would use focal versus global adenomyosis. Now we have to remember our patient also had 2 cycles of clomiphene citrate and 2 cycles of letrozole. And I wonder, when I receive her, if what the doses were, how were her response to that? And they said just time point 2. So it's very important now to elicit from her history what actually was done. Okay. And let's say, all is good, but then there was no pregnancy. And if she has superficial endometriosis, you can offer again ovarian stimulation, but this time with IUI and not timed intercourse already. And if she has OMA or DIE, then you talk about the possibility of surgery. But again, we don't want to do surgery. If we can go right ahead to do IVF, then that's an option. So I think it's important after your workup and after your history taking, do whatever else is needed and refer to your reproductive medicine specialist. Now, on the other hand, you see your adenomyosis. Again, if we're talking about focal adenomyosis, then there might be a chance. You can try ovarian stimulation with IUI. Again, we don't go on and on and on. So usually in 2 to 4 cycles, if there's no pregnancy, then remember she's 42 years old. You can refer her already. Again, if we're talking about global adenomyosis, then she might need to proceed to IVF with and without medical and or surgical treatment. Okay. Again, this is actually my last slide, and I'd like to end. We shouldn't forget the obesity of this particular patient, and it's very important to do preconception counseling, because even if she does get pregnant, then she has higher risk factors for miscarriage and complications. No? So weight management is very important. So weight loss interventions can be not only lifestyle modifications and exercise, but also medications and perhaps surgery for the extreme cases. No? And this is one part, the prevention of further weight gain, no? So hindi mag-weight loss, but at least hindi mag-weight gain yung pasyente, no? So I think that's a holistic way of looking at this particular case. So thank you again for the opportunity for me to go over this very toxic case. And I hope you learned something new today. Thank you.
Thank you very much, Ma'am Tonette, for that equally extensive discussion of the case. If you notice, the cases are complicated, and I have so many questions in mind already. I'm sure you have. So please type your questions. It can be anonymous, and then we'll discuss later. So our last case is a case of a postmenopausal symptomatic recurrent endometriosis. And Professor Eileen Manalo will discuss this case. Let me read the case for you. So ZE is a 52-year-old, Gravida 1 para 11001. She's a housewife coming in for insomnia and hot flushes and cold sweats. Wow, 10 times a night, my gosh. With history of thyroiditis, but currently she's clinically and biochemically euthyroid. So she had her menopause 2 years ago. 50 menopause, 52, she's symptomatic. From previous surgery, she had a laparotomy and a cautery of implants for severe pelvic endometriosis and adenomyosis. And she also had a primary low segment cesarean section. She had a history of bleeding at 43 years of age, where dilatation and curettage was done and an insertion of a levonorgestrel releasing IUS. 52 milligrams was inserted and then removed after 5 years. On pelvic exam, there is a retroflexed, bulky, and fixed uterus with no adnexal masses. There were thickened uterocecus and shotty nodules at the cul-de-sac. A transvaginal ultrasound showed adenomyosis with endometrial thickness of 0.46 cms and normal ovaries. The BMI is 23 kilograms per meter squared with hypertension stage 1 controlled by losartan. So now she's coming in for advice regarding the relief of her insomnia and hot flashes, which disrupts her daily activity. So there's a marked impairment in the quality of life, and advice on the prevention of further recurrence of her endometriosis. So Professor Manalo, Ma'am Eileen, kindly discuss this case with us.
Thank you, Duchess. Let me share my slides. Ooh, how come I can't find? I can't seem to share the slides. Siguro, Mona, can you share my slides? I can't see from here. I don't know how to do
Okay,
this.
Mona, share slide. Please allow Mona to share slide.
Ito, share screen. Okay, that's it. Okay. All
Yeah,
right.
ma'am, we can see your case. Okay.
All right, this is actually my case. So thank you, Duchess. And I'm so glad that I came after Dr. Delphine Tan, who gave a very thorough discussion of endometriosis, because his discussion actually is going to be very useful for my one. So I actually gave a very simple discussion here. All right, we have a 52-year-old. This is my patient. So she came to me for menopausal symptoms. She was being taken care of by another doctor, and she came specifically just for the management of her menopause. She's 52, G1P1, she's 2 years postmenopausal, coming in for severe symptoms of insomnia. And this is due to the hot flushes and the night sweats. She would get 10 times a night having chills, and this would disrupt her daily activities. And she also had decreased libido. So that wasn't mentioned. But of course, I know the details because this was my patient. So she had thyroiditis, but clinically, she was clinically and biochemically euthyroid. At age 38, she had severe pelvic endometriosis, diagnosed and underwent exploratory laparotomy for this. So there was also adenomyosis. And at age 40, she underwent a primary cesarean section. And she was hypertensive. She had good BP control. At age 43, she had abnormal uterine bleeding. A DNC was done, and Mirena was inserted and removed after 5 years. So family history actually showed her father died of colorectal cancer, stage 4. In personal and social history, what we have is a highly educated woman. Although she's a housewife, she's very active, does biking, aerobics, swimming, and actually she travels a lot. So she really was very disturbed by her symptoms. Okay, and okay, we move on to the next slide. I can't find the control here.
Ma'am, naka-slide view po siya. Is
Okay.
this in slide
Okay.
or there?
Okay, so let me just remove all this here up here. So PE, well, BMI is 23, 24, so not so bad. And IE showed a retroflex bulky uterus, thickened and fixed uterosacals and uterosacral nodules, as mentioned by Tonette, no? That we always do a physical examination. Never forget your physical examination. I see a lot of patients being seen by so many doctors, never been examined, never had a rectal exam and been seen by OBGYNs, and that's very disappointing. So here, without any ultrasound, I know that she had endometriosis. Without even telling me that she had surgery for endometriosis, I know she had endometriosis. So I did a workup, her thyroid function, I double checked it was normal, and I did my ovarian tumor markers because of the risk of malignancy as a woman gets older. So all were within normal limits, her CA125, CEA, CA19-9, and HE4. The ultrasound, of course, showed an adenomyotic normal size retroflex uterus, and the ovaries were normal, so there was no OMA. Lipid profile just showed slight elevation of her LDL, and total cholesterol was still within normal. And HDL was actually good, no? And she wasn't diabetic. Of course, she was already menopausal. So this could have been done away with. I don't even know why I asked for the FSH and LH. Mammogram baseline, of course, was normal. Okay. And okay, so I started her on calcium. This is 1,200 milligrams international. Sorry, that should be milligrams per day. And vitamins, vitamin D at 800 IUs. And I discussed with her the need for HRT. And my choice was really a transdermal estrogen with Mirena, because Mirena, of course, would have addressed the problem of endometriosis. But she opted, after a lot of discussion, she opted for a transdermal estrogen and vaginal micronized progesterone. She was very happy 1 month from follow-up. She had improved quality of sleep. She had markedly diminished hot flushes and chills. Now, 2 months from HRT, she started to complain of hypogastric pain and back pain, and she actually brought up the issue of hysterectomy. So at 3 months, we both agreed to do laparoscopic hysterectomy with BSO to optimize the effects of her HRT. And when I did her lap surgery, of course, this confirmed the impression of severe pelvic endometriosis with DIE and adenomyosis. And 2 months after, I put her back on transdermal estrogen and micronized progesterone. Okay, so I'm just going to give you a little vignette on postmenopausal endometriosis, and much has been said. And actually, what Tonette and Dr. Tan did was really a fantastic dissertation on endometriosis in the postmenopausal and the perimenopausal woman. So when we're talking about postmenopausal endometriosis, we have two specific concerns. One would be the reactivation of this endometriosis by exogenous estrogen, and this may cause a symptomatic recurrence. The other, of course, is the risk of malignant transformation from the residual endometriotic tissue. So malignant transformation is thought to be a multi-step pathway from a normal endometriotic tissue. It can convert into an atypical intermediate stage and into a frank invasive carcinoma. And you have contributing factors which actually affect the woman in the postmenopause. You have an increase in oxidative stress, increase in inflammation, and an altered hormonal milieu. Now, when you are giving estrogen, estrogen actually affects PTEN. PTEN, as we know, is important in your follicular activation. Okay, so PTEN expression in human endometrial cells with estrogen is associated with increased proliferation, a direct cell damage, and an increased risk of acquiring somatic mutations. So what I have here is just a pretty not so recent 2017 systematic review looking at women with a history of endometriosis who were managed at the menopause. So this systematic review looked at 39 studies, which included 33 case reports and 6 observational studies and clinical trials. And endometriosis recurrence was seen on women receiving HRT, and these were 17 women. The median age was 46. The ages range from 30 to 65. All had undergone treatment with exogenous estrogens. 12 of them, of the 17, had a prior hysterectomy and took unopposed estrogen. 5 out of 17 took combined HRT. And the median time from surgical menopause up to the time of recurrence was about 7 years. Okay, and the symptoms were pain, seen in 7. So this was found in the abdomen, the iliac fossa, the genitals, and the loin. Abnormal bleeding was noted in 14. This was presented as postmenopausal bleeding, vaginal bleeding or hematuria, or rectal bleeding or hemoptysis. 2 had pelvic masses, and the recurrent sites were mostly in the genitourinary tract, seen in 14 cases. So this is in the ureter, the ovary, cervix, vagina, the GI, and the rectum. And 2 even had involvement of the lungs and the bronchus. Okay, so management of postmenopausal endometriosis recurrence is tailored to the location and extent of recurrence. So basically, it has to be surgical excision, okay, of the endometriotic tissue. And you might want to add medical therapy. You can give your Depo-Provera, your danazole, or tibolone as suppressive therapy. Now, 3 patients resumed HRT after surgery, and 2 had estrogen-only formulations. Now, we look at the malignant transformation of postmenopausal endometriosis, and this now included 20 case reports involving 25 patients. So the mean age was 56, so older than the group which just had simple recurrence. So the ages were 38 to 75, and the patient characteristics were as follows. 13 patients had endometriosis in more than one site. 13 had histories of ovarian endometriosis. 4 had severe endometriosis. 4 had extensive endometriosis, and there were comorbidities. So leiomyomas were seen in 6, adenomyosis in 5. Surgical menopause patients were seen in 2, and 2 actually underwent oophorectomy at late stages at 60 and 57. Now, HRT commonly consisted of unopposed estrogen. So in 19, remember there were 25 women with malignant transformation, okay? And this unopposed estrogen came in the form of high dose CEE 125 or 0.625, which is the regular dose of CEE. They came in the form of estradiol implants, estrogen injections. Now, interestingly, we have a 75-year-old woman who developed ureteral malignant biliary carcinosarcoma with just phytoestrogen supplementation for 5 years. So take note that even phytoestrogen has been associated with malignant transformation. And in these women, median duration of HRT was 6.7 years with a range of about 3 to 20 years. Now, also, there was note of 2 women who stopped HRT and still developed carcinoma. So one was a 55-year-old who used estrogen implants at 50 to 100 milligrams every 6 months for 14 years post-hysterectomy and stopped for 8 years, but still developed adenocarcinoma and endometrioid adenocarcinoma. And one was a 55-year-old on estradiol 50 milligrams, also receiving testosterone at 50 milligrams, being given as 50 milligram implants, received for 12 years post-surgery, so post-surgical menopause, and was not on any form of HRT for 4 years before presenting with endometrioid adenocarcinoma. So malignant transformation, what would be the symptomatology? You have vaginal bleeding, pain in the abdomen, pelvis and buttocks, pelvic masses. Here now you have constitutional symptoms. You have weight loss, you have constipation. Flank pain, of course, is non-specific. Now, malignant transformation was diagnosed using Sampson's and Scott's criteria. This is, of course, you know from our rotation pathology that there has to be the transition from a benign tissue to a transitional and into a frank malignant tissue, okay? So these are the diagnoses of malignancies mentioned. So there was endometrioid adenocarcinoma, which was the most common. There was adenocarcinoma, clear cell carcinoma. So these are the ones that we really know. And this is what we tell our patients. Mullerian carcinosarcoma, endometrial stromal sarcoma, androgen-producing endometrioid borderline tumor, and adenocarcinoma, followed by an adenosquamous carcinoma arising in endometriotic foci 3 months later, okay? So the treatment for these patients with malignant transformation of their endometriosis would be varied based on the histological type, the grade and stage of the tumor, and you know that surgery is mainstay, and of course adjuvant or neoadjuvant treatments are given like chemotherapy or even progestin therapy. So the mean follow-up was 19.4 months and the range was 6 weeks to 5 years. Now, generally, the outcomes are favorable with no evidence of disease in 13 patients at follow-up. There was, however, note of mortality of 3 out of 25 patients. So outcomes are generally favorable. So tumors arising from endometriosis are typically low grade and have a better prognosis. There were only 3 deaths, as mentioned, reported in the literature. And in these 3 deaths, the complicating factors were that they were dealing with severe endometriosis. These were much advanced age, and multiple malignancies were noted. So the management, therefore, HRT, particularly combined estrogen and progestin regimen, is safe for postmenopausal women with underlying endometriosis. And it's important for us to take note that even women not on HRT can have recurrence, no? So if your patient is hyperestrogenic, so she's obese, she's had incomplete definitive surgery, she has residual ovarian remnants, and of course, if she has genetic predisposition, like this patient has a father who died of colorectal cancer. So all this can predispose to recurrence or even malignancy. So management, the current recommendations favor continuous combined preparations instead of adipose estrogens. Okay? So I think that would be it. And I will welcome all the questions that we can have after this. Thank you very much.
Thank you very much, Ma'am Eileen. Your discussion was very concrete and very straight to the point. Okay, so I'm sure everybody's excited with the open forum. I am excited. I have so many questions. Baka hindi ko na ho kayo mabigyan ng chance magtanong. But thank you very much for that lecture from BioFam. So maybe now call in to the virtual floor our speakers, Dr. Delphine Tan, Ma'am Tonette Habana, and Ma'am Eileen Manalo for our open forum. Okay. Again, congratulations. So para ho hindi tayo labo-labo, let's discuss the cases first, one case at a time. Okay? But all of you can answer. Dr. Tan?
Yes, ma'am.
Dr. Tan. Ayan. Paki-spotlight po si Sir Annie. Sir, kayong
Okay lang
start
sa
eh.
akin.
Case niyo yung first eh.
No, okay.
Yan. Okay. So to recap, the case of Dr. Tan is an OMA, which supposedly is asymptomatic, but Dr. Tan said there is no such thing as asymptomatic. So
For
50 years
postmenopausal
old,
women.
very young, 49 years old menopause, 1 year menopausal lang, and symptomatic. So sir, again, recap po, ano lang, straight to the point na, kasi I want this really management eh. What is your management option? Your
I'm
first
going to
is
remove
surgical. Remove, sir.
Yeah.
Agree
I'll
rin. Remove.
convince the woman to have it removed.
Yes. Okay. Sir, sir, if you remove po, sabi nyo nga, you have a choice, whether it's just a USO, you
Yeah.
don't want a BSO. You want, what is your priority? What is your first surgery?
Just as simple as,
Okay, so USO. So sige po, sir. If USO, susundan ko na ha. When do you start the MHT? Will you
Right
start
away.
your MHT? How soon will you start your MHT? Okay. Tapos tsaka si
What's
Ma'am
the
Tonette.
question? What's the question? Sorry.
Sige, sir, inoperahan na natin. USO na
Mm.
natin siya. Sasabihin ng pasyente, Doc, kailan ho ako magsa-start ng hormone replacement therapy ko? Ano po ang best agent niyo para sa akin? Let's say her SLE is okay. She has no flares.
Right away, even before she gets out of the hospital.
Yeah. So there's really no
No,
room
you
now,
know,
sir,
you don't
na
need
3
to
months
wait.
pa, we wait. Okay,
No,
second,
of course not.
what is your drug of
Because,
choice?
well, it's for patients with, let us assume that she has no endometriosis and she has no SLE, or you have to include all two.
Sige, kunyari nga, kasi sir, medyo complicated. Let's say, wala siyang SLE. She just has this OMA, which is like 3 cms. You did surgery already. She's normal body weight.
If the ovaries are retained, I mean, if the uterus is retained, it should be a combination of estrogen plus progestin. And right now, the choice is almost always now transdermal estradiol plus micronized progesterone or dydrogesterone. We are already past the age when we were prescribing combinations of estrogen with, let's say, the old or second generation progestins like levonorgestrel and PA and so on, because they're the ones that are supposedly associated with breast cancer. That's the reason why you should no longer be afraid of breast cancer, because you don't need to use them, because the newer ones do not have any association with breast cancer. even
Okay.
dirogesterone, even
Yeah.
Tibolon does not have any
Yeah.
association.
Yes. Apo. So, sir, I will reserve the other difficult question kay Ma'am
Now, the
Eileen
problem
mamaya.
here,
Yeah.
the problem
Apo.
here is that she has endometriosis and she has
Mhm.
SLE.
Apo.
In both conditions, whether the uterus was removed or not, she should be given progesterone
Mm.
or prevention of recurrence of endometriosis, and then to prevent
Mhm.
flares, because it is
Apo.
SLE flares,
Yeah.
because it is the use of estradiol alone that is
Mm.
responsible for some of the flares in women receiving MHT after the menopause with LSE. So those who are receiving combined E2, E plus P do not have any flares.
But sir, just to clarify, kasi sir, I think this is one of the should be the take-home message. Regardless of whether we remove the uterus or not, we should be giving our progestin, right?
For patients with
For
endometriosis
yes, okay,
and
yes.
for
So that
patients with
settled.
SLE.
Yes, so we're settled with that. So regardless whether you remove the uterus or not, you should give the progestin. Ma'am
The
Tonette.
the reason is
Sige po, sir.
because for endometriosis, the hysterectomy is not the treatment for endometriosis.
Oh, yeah.
It is hysterectomy plus removal of all the lesions
The
around the
lesions,
uterus.
yes po.
So if you just
So-
do a hysterectomy and you don't take care of extra gonadal as well as the
Yeah.
extrauterine lesions, it's really nothing.
Especially,
And-
sir, because this is a menopausal case. Diba? It's
Right,
different
right.
Kaya nga, my next question is, for Ma'am Tonette,
Teka,
sige po, sir. Sorry, sir.
my only concern is this.
Opo.
We have now proven that endometriosis lesions, whether post-menopause or premenopause, can produce its own estrogen because it has within the endometriosis locus the capacity for aromatase action.
Yeah, ayan.
It can
Sir,
get-
sinagot nyo na That's my next question What is the
It's na, alright.
pathogenesis of a postmenopausal endometriosis?
That's
So
a
it's not the
problem.
ovarian source. Opo.
It's adrenals.
Yes.
Or if
Sir,
you
it can
have-
be adrenal or adipose. Or the
Oh, yeah,
aromatase nga, sir.
obesity.
Oo.
Obesity.
Obesity.
Yeah.
Mhm.
So yeah, that my
Mhm.
next question. Ma'am Tonette, do you agree? Do you not have a cutoff?
course.
Let's say
We'll
3
agree.
cm, doktora, ayoko po Pwede bang mag-observe muna? If let's say the patient says, kasi, I'll give a different scenario. What if this is a long-standing OMA? Let's say, Ma'am Tonette, you had her at 45 years old. She has this 3 cm. And then at 50, she still has this 3 cm. Will you touch it? Will you operate on her?
So
Ginagawa natin
usually,
exciting. TA125 is normal also.
so the difference between this case and Dr. Tan's case is that we had her for a long time already, right? So
Kasi
we're
itong
pretty
case,
sure
hindi natin alam na
hindi natin
last
alam
year
kung-
lang
yeah. So the risk for cancer, di ba? I mean, in that age group naman, yun ang parati nating kinatatakutan. But if we've taken care of her for a long time, and we
Yes.
know it's been there, there's been
Yes.
no change, then we're more
Yes.
confident in observing. Rather than when it's a new patient coming in and she comes in already with a cyst and
Yes.
she's in that elder age group. Yeah.
Agree, ma'am. So, ma'am, in your case.
Can I make a comment? Can I make a comment?
Yes, sir.
The endometrioma may be non-changing, long-standing,
Opo.
but it is the age of the woman who's changing.
Yeah.
Yeah.
Okay.
She's 50 now or 52 now, and age is a risk factor for whatever cancer you may have.
Yes, sir. Sir, ang tanong sir nga is how do you do surveillance now
Oo nga
for
That-
cases like this?
Yes. That risk of malignancy
I do not
index,
know how to
sir.
answer that. Maybe
Opo.
Eileen can
No,
answer.
Ma'am Eileen and Ma'am Eileen, have you come across that risk of malignancy index or how to monitor supposedly asymptomatic cysts in a postmenopausal? Kasi let's say this is really, kasi sometimes sir talaga po asymptomatic. I have a lot of like that patients like that, yung itatide over mo lang.
Yeah.
Di ba may 3 cm ka, hindi naman pumapatak kasi 5 cm is the magic number Ma'am Eileen, do you have like how do you monitor?
I don't have an index, but you can argue. You have a patient who is 45, you've seen at 45,
Yeah.
and postmenopausal maybe 7 years later. So at
Yeah.
52, she still has the 3 cm endometrioma. You can argue you can have it removed because there's no source of
Okay.
estrogen for this endometrioma. So in
Yeah.
other words, there's no food source for the endometrioma. You can remove it. Then
Okay.
again, as mentioned by Tonet, if you have a patient who's pretty stable, she has good compliance, she regularly sees you at least once a year, and you're seeing 5, you're doing ultrasound, she's
Yeah.
still doing it.
Yeah.
You can just do nothing and just take care of her
Yes.
menopausal symptoms. So I think it
Yeah.
really has case to case. It has to be a case to case.
Yes. Agree. So that's what's important in this case, that not all OMAs we really need to remove. However, we may add, would you recommend adding Doppler to the monitoring?
Why
Diba,
not?
ma'am? And other comorbids, like if other comorbids, diba, with the patient, of course, always considering the family history, the weight, and the social profile. Yes. My next question, before we leave Dr. Delphine's Tan's case, let's say, kunyari lang po, sir, we did not remove the OMA, and then she's symptomatic. What MHT will you give? Is there
OMA?
any way? Sir, OMA, meron na siyang 3 cm, sis. Pero
Hindi pa daw
hot flashing siya.
pinatanggal.
Ayaw niya patanggal eh. Let's go to that.
Symptomatic. When you say symptoms of what? Menopause or
Symptoms of
endometriosis?
menopause, sir. Symptoms, she's bata lang, 50 years old
Still
siya.
a combined. It's still a
Combined, sir.
combined. Yeah.
Sir, have you come across, like, kasi there are newer, what is the role of letrozole?
Aromatase
Kasi di ba
inhibitors
yes nga,
for
sir. So,
postmenopausal endometriosis.
yun na nga, sir. So, do we reserve this for just residual, meaning those who you are, kasi I've come across really fine, or can we give this to this particular?
The studies on aromatase inhibitors are mainly for postmenopausal women.
Yeah.
So if you look at the
ito nga, sir,
at the
so
ESRE,
pag may OMA,
the ESRE 2022 suggests that aromatase inhibitors should be the treatment for postmenopausal endometriosis if surgery is not feasible. If surgery is not feasible.
Or sometimes
although this is the statement from ESRE 2022, if surgery is not feasible. Although I would like to tell you that I've been interested in aromatase inhibitors and postmenopausal endometriosis, and there is no evidence that it's good.
Tsaka it's so expensive, sir, no? Some would recommend using it sa case ni Ma'am Eileen. I will go later. Yung post-surgery and there's still residual. Patient is still symptomatic. So I will say that. I have so many questions also for Ma'am Eileen.
I think it depends on what the symptoms are. You're dealing with postmenopausal symptoms, so you address the postmenopausal symptoms.
Yes.
So if you're just worried about the endometriosis, persistence of the endometriosis, and she has no menopausal symptoms, you give her letrozole because it's anti-estrogenic. So it remember it's aromatase inhibitor.
Yeah.
So when you're giving you actually increase the androgen level here, which gets converted to estrogen. So when you do that, you actually promote further the estrogen activity.
But actually nga, ma'am, in some more recent, they do a combo. Like they even choose the Unogest as the progestin with that estrogen. So like the letrozole, some would give it together with the MHT because they're saying that because the pathogenesis of postmenopausal endometriosis is less on the ovarian source, but more on the non-ovarian. Agree? Yeah. So, yun nga, parang it's a bit interesting, but there is scars. But I just read on the Dienogest combining because Mirena, Ma'am Eileen, you put your patient on levonorgestrel. That's another nice option.
No, I did not.
Choosing.
I did not for her.
She came back. She came to you already. Yeah.
Right? And I recommend.
But that is a nice,
Yeah, I wanted to give her estrogen, a transdermal, again, levonorgestrel, but she said, nah, I don't want to have any more IUD, so she wanted another.
Okay, so we are done with case 1. So the first recommendation for this case, because it was a recently diagnosed OMA, we do not know the chronicity. It's best that we remove it. Yes, we will do the most conservative, especially she has SLE. Then yes, we can still give our MHT immediately post-op because she is symptomatic menopause-wise. Now, as to the choice, as long as her SLE is controlled, we can have our usual MHT always in the progestin, or Tibolone is even also a good choice.
Yeah.
right? Especially because tibolone, if the progestin is it's more progestogenic also.
It's converted
Friendlier
into
to the
three. It's
it's
converted
friendlier
into
to
three
the
metabolites,
yes,
which has
boss.
estrogenic, androgenic, and progestogenic
Yes.
effects. Yeah.
Okay, thank you. Now we go to Ma'am Tonette's case, another complicated case. So, this is a 42, so perimenopausal. Perimenopausal, the chief complaint actually is pain, dysmenorrhea, ma'am, di po ba? And then increasing menses, but she's also trying to get pregnant. So, Ma'am Tonette, thank you for that lecture. But if in a nutshell, may you please identify to us your chronicity of your chronological order of management. So in this particular
Your
case,
plan,
42,
plan.
what
Yeah.
is your plan?
Natawa si Sir eh. Kasi 42-year-old, sasabihin mo,
Oh.
bakit ngayon lang?
Yeah.
So,
2 years,
so
nag-clomiphene pa, tsaka letrozole.
yeah, so I would suppose that she already went to see a gynecologist, no? Kasi she already had the basic workup, no? So that's why I went through the rundown of, checking your ovarian reserve, which was done, the semen analysis, which was done, the HSG was done. So actually, ano naman, but then she was already given letrozole and clomiphene, 2 cycles each, to no pregnancy, no? So she comes to you, no? And that's why I think it's very important to get that commitment from the patient. No, we do have patients who shop around. Diba? They go from one doctor to the other. It's so hard to reconstruct what was done already and what needs to be done, and you don't want to repeat, all of this. No, and so I think evaluation is very important. So you have your baseline, but you can add on. We talked about the absence of any ultrasound findings, right? Or any clinical physical examination findings, and that's why I had to mention it. And all of that, your physical examination, your ultrasound findings will help you now decide what would be the best option. No, so again, it's a nice case because we don't know if we're dealing with a stage 1 to 3, 4 endometriosis or how big that adenomyosis is. So it can go either way. No, so again, let's assume that it's just a minimal or mild endometriosis. Then there might be some room for still doing 1 or 2 cycles of ovarian stimulation and do IUI. Humiling na si Doktora. Because if we can afford, let's go right ahead. She's 42 years old, you don't want to waste time. So it's always in that background, I mean, if she was 25, maybe we can wait some more, but at 42, but then again, that's why I listened to this nice discussion in an ASRM podcast, and they always brought it back, I mean, what is available in your setting and can you afford it? And that's why in our setting, it's a little different. I mean, it's easy to say, let's go IVF, but it's not accessible for everyone. And that's why there's that option to do this. But then, after 1 or 2 cycles, please refer to your favorite reproductive medicine specialist for a more holistic management for this case. So it's a tough case, but we do see these cases, in our
Yes,
clinics.
ma'am. Ma'am, especially because now, so ma'am, it's clear, no, we will prioritize fertility. Diba? We will get her pregnant first. Or what?
Yes.
Ma'am, if you notice, when we have these patients, the pain is intense when we stimulate. Ma'am Eileen, do you have any comments? Raising your hand. Yes, ma'am.
Analysis by Bercellini. And the end result there is if you're doing IUI, you're actually causing the endometriosis to progress. So the thing to do, you have to weigh the risks and the benefits. Our patients usually cannot afford IVF, but when the patients will come to you as a fertility specialist, that is the first thing you offer the best, and anything else is inferior. So you offer the best, and this would have to be segmented IVF. You give the patient your controlled ovarian hyperstimulation, you do your egg freezing, you do your egg pickup, you do your embryo freezing, and then you give your patient GnRH for 2 to 3 months. depending on the size of the uterus, you want to shrink that uterus because she's adenomyotic, so that it'll be more receptive. You want to improve on the endomyometrial junction, and then you do your embryo transfer. She has a diminished ovarian reserve, so you want your priorities to get her pregnant as soon as possible. So anything less than that is really just going to prolong the agony for the patient. Okay, and so at the end of the day, you have to give her what is best. And most of the time, these patients will come up with, the necessary finances to carry out the proper procedure. They would still be spending 25 to 40,000 a month if they're doing IUI. They're prolonging, the pregnancy, the time to stimulation to the time of pregnancy and delivery, and they are promoting the progression of endometriosis that way.
Yeah, Ma'am Eileen, thank you for that. So yes,
That just can I make a comment on
of course, sir. Of
patients who
course,
can?
sir.
We keep on saying patients can't afford an IVF,
Yes,
but they can afford to get pregnant.
yes,
In the long run, it's much
exactly.
more expensive than an
Yes.
IVF. So I said, if you can't afford an IVF, don't get pregnant anymore.
Ay,
Sure
suplado.
naman.
No, my,
Putik.
my point is,
Elitista.
right, right.
No,
But
but sir, I see. Yeah, we see your point, sir. So yes, ako
it's
rin, I
better.
agree with Ma'am Eileen. Opo. The
It
first
would be
line
nice.
actually.
It
Opo.
would be nice if we just have deliver a baby and we don't have to educate this baby and have to feed the baby and maybe go up until she gets married. So this expensive proposition to get pregnant.
Please, sir. Ma'am Eileen? Yes po, ma'am.
Another point, when you try to get these patients pregnant, when you do IVF, they're always asking for twins. No? And you have to make them realize that if you have an adenomyotic uterus, endometriosis by itself, and adenomyosis, so with superimposed adenomyosis, already
Bad
increases the
combo.
risk of
Yeah.
miscarriage, already increases the risk of preterm delivery, and
Yeah.
so you do not want to encourage them to have twins. Of course, if you're dealing with twins, you just take care of the twin pregnancy, but you do not want them to have a twin pregnancy. So you tell them it has to be a singleton pregnancy because the uterus is hyper irritable in such cases.
Yeah.
So it's
Thank you,
yeah.
ma'am. Yes. Ma'am Tonette?
It's a
Yes,
very So it's a very bad combination, having endometriosis and adenomyosis at the same time.
Yeah.
And so I think as for the general OBGYNs, the recognition, just working up the patient and recognizing, that this is going to be a high risk kind of infertility patient because you're running against time. I think that's the thing here, no? You don't have the pleasure of waiting and trying, no? Like even among our young patients, we say, tops na ang 6 IUIs, 4 to 6, then you better move on, you don't go through it, 3 years. And sometimes you have patients like that, especially in a patient at 42, you're really running after time. So the sooner they're referred, the sooner they're attended to by specialists, I think it would be best for the patient. No? And I'm very happy to note that there are more and more IVF centers around our country. Ma'am Eileen, I think we have around 9 already, and hopefully we'll have more in the future to make it more accessible to our patients.
Right.
Yeah. Yeah. So this case is difficult, but I think the eye opener here is yun, ma'am, identifying the high risk scenario of this case, knowing when to refer, and then I think Ma'am Tonette mentioned in this particular case, we do not suppress kasi we want them to get pregnant. That's very important kasi sometimes, ma'am, we get cases na nakasuppress po yung pasyente. So, hindi natin sila masistimulate agad. So, the patients will go back to you. When you refer them to an IVF specialist, as soon as they're pregnant, they are returned to you. And then, Ma'am Eileen's comment of shrinking, that's very critical. Kaya nga, yun yung you stimulate them, then freeze, shrink, then transfer, pregnant, back to the OB. Okay? So this case is very well discussed. Sorry, I failed to ask some questions here kasi sinasala po namin yung questions sa chat box. Yung medyo hindi po related. Baka the speakers can just type the answers. We want the questions that are related to the case. For Dr. Tan, sorry, let's just go back to one question. How long will you give combined MHT in patients with endometriosis after doing USO? Can you shift to pure estradiol later? So this was from Tess Batayo.
The answer is no. Okay, I'll
Yes,
give it for
okay.
as long as necessary, meaning as long as there is benefit. I will not
Okay.
shift to estrogen alone because we have seen, and there has been reports of postmenopausal endometriosis even up to age 80 or above. So it's
Yeah.
not just a phenomenon in the first, let's say, 5-10 years after the menopause. The oldest woman that was seen with postmenopausal endometriosis is about 83 years. And it can still be there. So just go on with your estrogen plus progestin combination. But just
Thank
choose
you.
the right progestin
Yeah. Thank
and
you
the
for
right
that,
route
sir.
of estradiol.
Opo. Ma'am Tonet, maybe you can answer this. Why is, from an anonymous, why is adenomyosis and myoma uteri stated as special precautions regarding the use of the Enoges?
I'm wondering also, did we mention
Mhm.
that? I'm sorry.
The Enoges, this is really for the, because some studies show also treatment for treatment of,
adenomyosis.
yes, for the
Yes,
Enoges.
there are more
Yeah.
studies coming out now that you
Yes,
can use
yes.
the Enoges for adenomyosis.
Mhm.
Can I explain it?
Minsan lang
Yes,
kasi
go ahead.
nagbi-bleed sila eh. Sige po, sir.
I think the reason is because the Enoges is approved only for endometriosis. It's not approved for adenomyosis. It's not approved for myoma.
myoma. Yes.
So if you use it
And
as for myoma and
off-label.
adenomyosis, these are off-label uses.
Off-label use.
It doesn't mean it's bad. It means that it is not the ones that are approved by and the company doesn't want to recommend you using this for uses other than the label indications. But it doesn't mean you can't use it. It depends on your judgment, your expertise, etc.
Yes, Ma'am Tonet. Opo. Ay,
No,
Ma'am Eileen, sorry, Ma'am
Ma'am
Eileen.
Eileen.
Sorry po, Ma'am Eileen, sorry. Yes, Ma'am Eileen.
I wanted to add that the Enoges is also a progestin. And remember that myomas also feed on progesterone growth. No? It's just that we do give Enoges for control of bleeding in patients with myomas. We also give them for adenomyosis. But as mentioned, there are no RCTs. There are no RCTs as far as,
and sometimes they bleed more, Ma'am, diba?
When there are RCTs, the Japanese RCT by Usuga, meron.
Adenomyosis, di ba? Parang I remember so.
Meron na
Yes,
sa adenomyosis.
And also with
Enoges plus adenomyosis.
Yeah. Again, for Dr. Habana, is adenomyomectomy an option for case 2?
So now there's greater interest now in doing surgical management of adenomyosis. Why? Because of the poor outcomes, no? But then wala pa talagang if you notice dun sa I had one slide but I didn't really go in depth kasi parang it's more for an RM already where you have those different sizes
reproductive
of your
age pa yun, Ma'am.
Yes, and then you can do hysteroscopic resection now of adenomyosis just to improve on the endometrial lining and perhaps even adenomectomy if it's quite large and so forth. No, but again, no RCTs on that one. Very few surgeons actually do it. So I guess we'll have to wait for more data before we will advise or recommend its use. Yep, Ma'am Eileen.
There are indications for doing adenomyomectomy. So generally, you don't do it because the outcomes are poor. Majority of the cases, usually live births will be about 68%. So you do it when you have recurrent pregnancy losses, not due to other causes. You have recurrent implantation failure. If the patient has persistent disease, it is a very symptomatic despite medical management, so failed medical management. So those would be the 3 cases. So I just did an adenomyomectomy earlier today, but the point is this patient is desirous of pregnancy. She's never had a miscarriage. She's never had an implantation failure. She's only tried letrozole and clomiphene. So definitely, I personally would not recommend adenomyomectomy.
Failed medical management, Ma'am, for the pain can also be an indication for the adenomyosis. I think this was already answered. For Dr. Tan, in asymptomatic OMA in the menopause, is there a role for like the one I asked, the risk for malignancy index, but Dr. Tan said, sir, parang you have not come across that, yung risk for malignancy index.
I no, I don't.
Yeah. Pero yun na nga, we can, yes po, sir.
There's something I'd like to say. If you're considering malignancy, it doesn't matter whether it's asymptomatic or not. Malignant tumor doesn't have to be symptomatic to be considered malignant. It doesn't mean, and it doesn't have to be a big size of a tumor. I mean, all tumors, malignant or not, start small.
Okay, so well said, sir. Yes.
Consideration of malignancy, you go for surgery.
Yeah. Yeah.
I think the age is a more important risk factor.
Yes. Again, very excellent discussion. We now go to the last case, Ma'am Eileen's case. So this patient, she's 52. She had her menopause at age 50, and she is symptomatic for the menopause and also for the endometriosis, ma'am, ano?
No, she wasn't symptomatic to the endometriosis yet.
She's sick. Okay. And then later on, she developed,
She had endometriosis. She knew it was severe endometriosis, but she was asymptomatic as far as the endometriosis was concerned, but she had very bad menopausal symptoms.
Yes. So, ma'am, I think this question may be best for you to answer. Comment on the management of intrauterine tumor progression and malignancy prevention when discovered during the course of pregnancy in the perimenopausal age. Baka kay Ma'am Toneto.
Ano yun?
Comment on the management of intrauterine tumor progression and malignancy prevention. Siguro, ma'am, an endometriosis turning into a malignant.
But she's pregnant.
And malignancy when discovered during the course of pregnancy in the perimenopausal age. Who wants to answer this?
She's pregnant. Yes, a tumor got bigger.
Yeah.
Mo.
So we will wait for depends on the age of
ovarian cyst during pregnancy, di ba?
Yes.
Pregnancy with an ovarian new growth. So we'll treat it as such.
If you're ruling out malignancy, you can do your surgery during the pregnancy. Otherwise, it's behind, you can leave it behind, which is an important issue, no? We see a lot of patients who have pong, pero endometrioma, inooperahan. Hindi kailangan. Okay? So you can actually take care of the pregnancy and deliver. The only time that you're going to do your surgery especially it's very hard during pregnancy. You do laparoscopic or open surgery, grabe indicate usually posterior yan. Then it's hard to access, especially if you're dealing with an enlarged uterus, more than 24-week size. So don't touch it. No, you don't have to touch it unless you're thinking malignancy. And then you can just take care of it, deliver the patient, and then you worry about monitoring the cyst, or maybe you do your surgery afterwards. Laparoscopic surgery.
Ma'am, in your case, she's a vibrant 52. She swims, and yet you gave her transdermal estradiol. Why? Why not choose that?
She's hypertensive.
What, ma'am?
She's hypertensive.
She's hypertensive ba?
Yes.
I didn't see that. Oh, yes. Let's say she's not hypertensive.
No, you can give your oral. Ngayon, ang problema natin is availability of the HRT. It's not so much the best HRT, it's what's available.
Yes.
So
and this young
transdermal, because patients as they go through the menopause become they have the problem of metabolic syndrome. They are predisposed to coagulation, to higher risk of stroke, even without HRT. And so you want to give something which is safer for them. So this patient definitely, despite the fact that she's an active life, she is a good weight, still you want to prevent risks for the patient, so you want to give her a transdermal.
Ma'am, if the libido is a concern, is like Tibolone really ahead compared to their transdermal? You have the answer to that.
Hindi ko ang concern, Tibolone ang binibigay ko. Kasi wala tayong androgens. Wala tayong androgens.
Pero ma'am, transdermal also has that edge. It also does not dampen the libido.
But remember, androgen is better.
Yes.
Better treatment.
Kasi I was thinking of this patient, she's 52, biker.
Oh,
The
she's
bike
happy
also
now.
complained. Oh,
She's happy now. Diba?
which is good.
Happy.
Yeah, which is good.
Tibolone.
Yeah.
Remember, Tibolone is a designer drug. It has estrogen, it has progesterone, it has
Yeah.
estrogen. So,
So
yun.
so you gave her Tibolone, not the you gave her transdermal, right? And the micronized. Okay.
Happy naman siya eh. Oh, she's
Yes, yes.
sexy active again.
Let's say, example, again, you decided to give her MHT combined. Is there a difference regarding endometriosis recurrence whether you give the combined, continuous combined, meaning estradiol progestin full 28, or the cyclic progestin 14 days only? None.
Wala nang
Yeah.
cyclic na yun.
Evidence of
Ay, hindi,
Sequential.
sir,
I
pwede,
don't-
ayun nga, ibig sabihin, sir, pwede pa rin, sir, 14 days progestin, di ba? 12 to 14 days, tapos po, estradiol, or give, kasi di ba, sir, pag reproductive age, we suggest the
but I
continuous
would-
is better.
I would suggest the continuous or estrogen progestin.
Opo.
You have
Pero
to hold that.
lower.
You have to hold that endometriosis under control
Yeah.
all the time.
But again,
Sir,
caution, it's a lower dose.
Sir,
Oh,
kung
ma'am?
hysterectomize na, wala nang issue eh. Di ba? It's only if the uterus is there. There's a potential for bleeding and you don't want the bleeding because that will further aggravate the endometriosis.
But even
But
if she
ma'am,
has
even-
hysterectomy, you still have to
Yes.
continue with estrogen plus progestin.
Yes, but sir, you may give either.
Yeah, you
Our
can give
problem
the,
is the availability. A lot of times, the 100 milligrams of micronized
it's not
progesterone
available.
is not available. So they end up getting the 200 milligrams. So for 12
The,
days.
the only
Yeah.
problem I have with this argument is that we still don't have any study that will show the efficacy of micronized progesterone in preventing recurrence of endometriosis. Because it has not been used for endometriosis.
Yeah. Yes, sir. You are right, sir. The study is mostly on Provera. Yeah, that's why nga there's a combo even of the Unogest, levonorgestrel releasing IOS, or Tibolone as comparable to your MHT combined. Yes. What about the risk, Ma'am Eileen, baka you will answer, what about the risk of other cancers emanating from a chronic MHT?
O di ba nga, I reported on that.
Ano nga,
Yeah.
what is the parang list with regards to the progestin component? Did you mention that?
No, I didn't
Well,
mention
that's breast cancer.
The one,
Because
yeah, the one not
Kasi the others, yes,
yung
ma'am. The other side,
dydrogesterone
opo,
and
ma'am.
then micronized progesterone are not associated with an increased risk of breast cancer,
Yeah.
but not in terms of the other cancers. Wala talaga.
Yes. Yeah. So it's relatively safe to give as long as the patient needs it.
now for breast cancer, all the studies in the WHI which used estrogen only did not show any increase in breast cancer. There was actually a decrease in breast cancer. The increase in breast cancer were seen only in those who have received a combination of estrogen plus progestin. And please remember the progestin here is MPA, which is not a very good progestin as far as the breast is concerned. Actually, to the breast, MPA could be considered an endocrine disruptor.
Okay.
Lost my audio. Can you hear me?
Lana?
Yes.
Yep, so we're good.
Sorry. Anything else? So I think my boss is telling me to stop already. Thank you very much. Any parting words from our speakers? Super nag-enjoy ako. Super high yield. Dr. Tan, last one sentence.
Well, be careful.
Sir?
Be careful.
Be careful.
Whatever you do, whatever you decide.
Premium non chere.
Yeah.
Wow.
Yeah.
Latin pa yun.
First, do no harm. Always think
Yeah.
of your patient's benefit. Think of your patient as your relative when treating them.
Yeah.
Thank you very much. Maraming salamat po. Sobrang dami nating natutunan. Professor Delphine Tan, Professor Tonet Habana and Professor Eileen Manalo, maraming salamat.
Thank you.
Also want
Thank
to
you.
thank you. Closing remarks na po ako. I would like to thank our sponsor, BioFam, especially Connie. She has an emergency, so she cannot come and say her parting words. We would like to present our certificates of appreciation. Quick lang. Can you please show certificates of appreciation to our distinguished speakers for their invaluable contribution to this day's webinar. Okay. Next, please. Sige, go ahead. Yan. To all our speakers and also to BioFam. And we would like to invite you. I would also like to thank our CME team, especially Mona and Nay, who always come up with an impeccable program and a great list of speakers. So si Mona ngayon yung tag for July. And also Rose for yung kasipagan mo. And we would like to invite you, last slides please, to our our last MENOTalk Wednesday will be on August 10. Again, sorry, it is not the first Wednesday of the month because of a conflict of schedule with our speakers, but the topic is equally interesting. It's on the management of cancer survivors in the menopause. And we have our lecturers are as Dr. Ricky Luna, past PSCM president, and the current secretary of PSCM, Dr. Agnes Estrella, and the moderator is Region 4 Regional Director, si Susan Cantor. Okay. We would also like to invite you to our annual convention. So malapit na po. So this is on September 1 and 2. The theme is Global Management of the Woman at Midlife. And we are fortunate to have with us 4 international speakers in addition to our also well-renowned local speakers. And just to remind you that we will have our election of what happened? Our election on September 2. So there will be a business meeting on September, the 2nd day at 3 o'clock. Okay. And other conventions. So we're part of the PSC POGS Pre-Congress. So the POGS Pre-Congress will be on October 11. So this is the PSCM session, and the bulk of the discussion will be on depression, dementia, and sleep disorders in the menopause. And we have our speakers, Dr. Patrick Moral, to discuss sleep disturbances in the menopause. Again, Dr. Delphine Tan to lecture on perimenopausal depression. And lastly, combination of a gynecologist and I think this is an internist, spectrum, a neurologist, spectrum of dementia in the
Neurologist is
Sir, ma'am?
Neurologist.
Oh, neurologist nga. Drs. Lilia Luna and Dr. Darwin Dasig. Okay. And lastly, of course, PSCM is part of the POGS annual convention, and our session will be on November 10. And these are our topics. Again, si Dr. Tan is our speaker to lecture on the perimenopause as a neurologic transition state, lifestyle management and supplements in the menopause, to be lectured by our president, Dr. Prudence Aquino, and the first starring lecture of Mona, Eusenolos, Progestin, and MHT. So if you look at our roster of activities, we're very much active in with our webinars and also with POGS. Okay, I think that's the last slide, ano? So you please fill up the evaluation form to get your certificate. Maraming salamat, and see you all again on August 10 for our last webinar of the year. For the panelists, kindly turn on your video for our Kodakan, picture taking. Thank you very much.
Meron pa akong tech run.
Ay, ito na nga po. Turn on videos na.
Okay.
Thank you.
Aileen,
Thank
tapos
you.
na yung tech run.
Tapos na?
Tapos na.
Magpa-private tech run na lang daw po kayo.
Okay.
Saan yan, ma'am? PSFP? O sige.
PSRM.
Ako na yung camera ng mga remove the spotlight from me.
Si
Please.
Doc Nay.
Thank you everyone.
Ayan, sige pa.
Thank
1, 2, 3, smile. 1, 2, 3, smile. Okay na po.
Thank you very much, everybody. Thank you.
Bye, Duchess. Good night.
Thank you po, Dr. Tan. Sobrang galing. Maraming salamat.
Basta ikaw.
Hiramin ko yung sources, sir, ng iba yung lectures. Thank you very much.
Problem.
Sir, Dr.
Give Donna the slide so you can get it from Donna.
Oy, thank you naman, sir. Sige po,
Ken
tinitingnan
Mona
ko
pala,
kasi
Ken Mona.
yung ibang question, baka hindi natin nasagot yung iba nilang tanong eh.
Yung ibang question sinagot ko sa ano.
Oo nga, sir, nakita ko. Thank you very
ah.
much. Kasi yung iba naman, nasagot na natin during the discussion eh.
Right. Yeah.
Okay, thank you po. Enjoy your food. Ingat, everybody. Thank you po.
Annette, bye-bye. Eileen, bye-bye.
Bye, Dr. Tanet, Dr. Eileen. Thank you.
And dito pala si Boss. Boss, thank you. Bye-bye.
You're my boss, sir. Thank you. Bye-bye.